That would mean to say that you have regurgitation. So, regurgitation, murmur, can be heard because of the turbulence. Turbulence will be noticed as a sign when the doctor is trying to auscultate the patient. So, when the volume of blood is same, but the space, that is the valvular diameter, is shrinking, that will lead to stenotic murmur. And we are establishing the fact that in case of endocarditis, we can expect murmur, be it acute endocarditis or subacute endocarditis. In case of acute endocarditis, you will expect regurgitant murmur when the valves have been destroyed. But in case of stenotic murmur, the valves are not destroyed. The space through which the valves allow the blood to flow, that space is narrowing, because of which you can expect stenotic murmur. So you expect subacute bacterial or fungal endocarditis. Let me discuss the logic sooner, but here imagine this. In case of acute endocarditis, turbulence is happening because of regurgitation. Now in case of subacute endocarditis, you can expect stenotic murmur. Now look at this part. Here, in case of microbiology, you can think of regurgitant murmur and stenotic murmur depending upon whether the valve is intact or the valve has been shrunk, whether the valve has been destroyed or the valve's intactness has been compromised. Now, you also will have one quality of murmur that can make a difference. See, you may have systolic murmur, you may have diastolic murmur. Remember, the most common murmurs are systolic murmurs, and the most common systolic murmurs can be found in case of athletes where the volume of blood pumped across the heart is generally higher. Now let's look at how you can identify whether it is systolic murmur or diastolic murmur. Now imagine this noise. If I hit it once, it's called as lub. The second time, it's called as dub. Now watch very carefully. Lub dub, lub dub, lub dub. Now watch this. Now this rub is actually an expansion, an explanation, a description of the murmur. So we have S1 and then a murmur, then S2, again S1, murmur, S2, again S1, murmur, S2. We have now listen to this murmur. Here you will be having S1 followed by S2, then murmur, again S1, S2 followed by murmur, S1, S2 followed by murmur. Between the S1 and S2 we have the phase for systole, so this would be systolic murmur and this would be diastolic murmur. Now if the murmur is happening exactly at the midpoint between the S2 of the first cardiac cycle and the S1 of the second cardiac cycle, and if it is happening at the midpoint, you call it as mid-diastolic murmur, which happens in case of mitral stenosis, which you would be learning in detail in case of general medicine and cardiology. Now, if you think of aortic murmur or aortic stenosis, what kind of murmur can you expect? Now keep asking yourself such questions and see the timing of the murmur. Now I have shown you how the murmurs would exist. Now look at this part here. These are the areas where vegetations are noticed in the valves. Now this particular valve is not a healthy valve at all. This is a healthy valve. This is a vegetation filled valve. What can be present in the vegetation? The moment I say it is vegetation, the concept of acute bacterial endocarditis has been brought down. Instead, you will be having subacute bacterial endocarditis or chronic bacterial endocarditis. Now, what is the concept in case of subacute bacterial endocarditis? Imagine this. If this is the schematic representation of the valves, say, for example, the dotted areas are telling you the superior surface of the valve. Now, blood is trying to travel from the right atrium into the right ventricle through the tricuspid valve. What happens? The blood is forcibly going through the particular valves into the right ventricle. At that point of time, some amount of bacteria who are carried by the bloodstream will try to take rest on the superficial surface or the superior surface of the valves. Now, if I zoom this, if this is the valvular space, let me redraw this. If this is the top or the superior surface of the valve, you will be having bacteria settling here. Now, what kind of bacteria are they? In case of subacute bacterial endocarditis, you are dealing with moderately virulent or mildly virulent bacteria. What does it mean? They will not have the same propensity and virulence like that of acute bacterial endocarditis causing bacteria like that of Staphylococcus aureus. The aggressiveness will not be there and the vociferous eating will not be there. They are not violent, but they are negotiable. It means the bacteria, number one, do not eat the valves. They are amenable for negotiation. They settle on the valves. When they sit on the valves, during the flow of blood, your inflammatory cells and leukocytes will be alarmed. They will decide to see whether these bacteria who are staying on the surface of the valves are dangerous. So when the bacteria settle on the valve and stay quietly, the WBCs also will come and stay around the particular organism and ask them, hey, what is your plan? Why are you staying there? The bacteria are saying, no dude, I'm really not actually in a mood to destroy anything. I just want to take some rest. Please don't disturb me. The WBCs are saying, really? Are you actually in a mood to take rest? Okay, if that is the truth, we will stay along with you. We also will take some amount of rest. At that point of time, a negotiation has been established. If it was Staphylococcus aureus and it sits on the valve, if it is highly virulent and coagulase positive, when the WBCs comes and say, hey, what's up? Why are you standing here? They will not listen to the WBCs. They'll in fact destroy the WBCs. They are leukocidal in nature and they'll destroy the valves and eat them. But these organisms are not so highly virulent, right?